Today we are discussing a very important topic of menopause hormone therapy. Let me tell a few lines about it, that how concept of menopause therapy started, and it was the brainchild of Dr. Rama Vaidya, who only told in the beginning that menopause should not be taken as a deficiency disease. There should be a holistic approach for menopause, and on this we worked out, and we reached to a stage what we are today. We will be highlighted by Dr. Mehta, and everybody has been sent the recent guidelines also. If you have not gone through it, please go through it. Now I start my first session. Our first speaker is Dr. Shraddha Agrawal. She is a senior consultant, obstetrician, laparoscopic gynecologist, and reproductive medicine specialist. And what is her topic? She will be speaking on definition and indications of MST.
Thank you very much, ma'am, for kind introduction, and welcome President IMSCON and senior delegates here. My talk is on definition and inductions of MST. I think this is a very important topic for the current scenario, because as we know that 51% of women form the global population, and 25% of them are somewhere suffering from postmenopausal symptoms. Some women have debilitating problems with menopause. So here I'm here to discuss what it means, so that we all are on the same page, the same definitions, and the indications. I've tried to summarize the European guidelines, which is 2025, which is slightly different from what we used to say about MST. And I've also tried to say something about the molecules to be used. So what are the indications, and where should they be used, where they should not be used, just to make it more effective and make your time more fruitful, so that we can all change something in our practice from today's message. Thank you. I'm just going to start my talk now. So menopause, we all know that 12 months of amenorrhea and it is menopause. Median age globally is around 51 years, so 50 to 52 years. Perimenopause, however, we need to understand is the period from where people have vasomotor symptoms, menstrual irregularity, or loss of periods with lot of debilitating symptoms. Perimenopausal definition is transition from perimenopausal period to 1 year of postmenopause. So we need to really look into this, that perimenopause is not before just menopause, it includes 1 year of menopause also. Postmenopause is after final menstrual period. Early menopause is between 40 to 45, and premature menopause is less than 40 years of age. Now this has been explained by a table. These are a straw classification. This is done to better understand the thing about it. So we have reproductive years, where we have early, peak, and late. Late, you can see that FSH starts rising. Then we have like -2 to -1. These are the perimenopausal periods. Early is when we have just menstrual irregularity, maybe delayed periods by 7 to 10 days. And then we have late perimenopause, just before menopause, which could be like irregular cycles, period of amenorrhea. And then we have the last or the final menstrual period, and following that is the postmenopause. Postmenopause is also early and late menopause. Early is like 5 years into menopause, and late is up to demise. So early is also classified into 1 year of menopause and 4 years of menopause. This is just to talk about, when to give, what to give to the women. So again, this is the slide explaining it all. I'll just say that straw criteria define perimenopause from -2, -1 to +1, that is 1 year of postmenopause, ending 12 months after final menstrual period. Most important is POI because we have periods of amenorrhea, vasomotor symptoms, fertility. Diagnosis is by a lot of exclusion, history, habits, but it is day 2 or more than 40 years of amenorrhea. If we do FSH levels, one level of more than 25 IU per liter establishes the diagnosis. Then early menopause is between 40 to 45 years of age. Again, a lot of symptoms, vasomotor symptoms, periods of amenorrhea, hypomenorrhea, fertility, subfertility, and FSH on 2 occasions of 25 international unit per liter of more than 25, 4 weeks apart establishes the diagnosis. After 45 years of age, we don't need any biochemical test to establish the diagnosis. So what is the physiological basis? Of course, it is the cry of estrogen lack. So it feedbacks, and there is hypothalamic thermoregulation, dysregulation, increase GnRH pulsatility, increase FSH LH to bring out estrogen, but of course the ovaries are sleeping now, and there is neurotransmitter imbalance, accelerated bone resorption, endothelial dysfunction, urogenital atrophy, and adverse lipid profile. So this is just the table telling us, the types. We know estrogen can only without uterus, combined sequential transdermal oral tablets, vaginal estrogens, tibolone, and SERMs, that is benzodoxifene. So primary indications, this is very important slide, moderate to severe vasomotor symptoms, genitourinary symptoms, prevention of osteoporosis in high-risk women, premature ovarian insufficiency, early menopause, quality of life impairment, sleep disturbance due to vasomotor symptoms, and surgical menopause. So what are the recommendations? Recommendations are you need to have a holistic approach before prescribing MHT. They should have good counseling with risk and benefits of MHT. Alternatives should be discussed, like cognitive behavior therapy, complementary therapies. If they have intact uterus, estrogen and progesterone should be prescribed. Without uterus, estrogen alone is sufficient for MHT. No added benefit of progesterone. Individual characteristics, comorbidities should be taken into account when prescribing MHT. Preference, availability, costs, and should be taken into consideration. HRT should be prescribed in premature ovarian insufficiency, irrespective of vasomotor or climacteric symptoms, because multimodal benefits clearly exceeds the risks. Mainly, it prevents osteoporosis, cardiovascular protection, and improves cognition and sexual health. HRT should be at least given up to natural menopause, and then they should be counseled about what they want to do after that. And if it is POI, they should be given good amount of estrogen. What is the maximum dose we give? Because they need that level of estrogen to have the benefits of prevention of osteoporosis and CVS benefits. That is CVS protection. This is very different from previous guidelines. Previous guidelines used to say like 50 years, vasomotor symptoms, give it for 1 or 2 years. This is the real change which has been brought up in the European society, that initiate MHT within 10 years of menopause or less than 60 years of age for bothersome menopausal symptoms. That is recommended. MHT also prevents osteoporosis and decreases fracture risk. It has also positive effects on cardiovascular system, being cardioprotective and favorable lipid profile, which has been established up to 60 years of age. Previously, it was like 50 plus 52. This is very important. Again, vulvovaginal atrophy, genitourinary symptoms, local HRT is the best, if any concerns or contraindications. Even in local HRT can be given even in breast cancer patients, systemic HRT when required. Again, the next point is very important. Without symptoms in a woman less than, it is more than 60 years of age, MHT indicated for bone protection. So previously it was no, more than 60, no. But now, good counseling, having all the comorbidities, they can still be counseled into having MHT for vasomotor symptoms and bone protection. So let's talk about specific situations. Specific situations, again, as I was talking about, age more than 60. Now the population is aging, and women are surviving much more than they used to after 50 years of age. So more than 60 years of age, if they are suffering from vasomotor symptoms, we need to assess the risks and benefits. It does have positive effect on osteoporosis and fracture risk, which is a major concern in old age, just as trivial fall and fracture femur. So personal preferences should be taken into account, and they should not be bereaved from offering MHT. VTE risk, previous VTE, MHT after individual risk benefits. Again, this is very different. Previously, previous VTE, no MHT. Now, if it was like a trivial thing, then with counseling and with better options where there is reduced risk of MHT, menopausal hormonal therapy can be prescribed. So transdermal route is preferable. Always remember that. And even if the woman has uterus and you have to give progesterone, short tibolone can be considered, because tibolone actually does not increase the risk of VTE. But if they have family history, congenital thrombophilias, and which really predisposes for VTE, then they have to be counseled, and it could be a relative contraindication. CVS, MHT not for primary or secondary prevention. Diabetes, if it is well controlled, transdermal route is favorable. Hypertension, if it is well controlled, transdermal can be used. So hypertension is no more a contraindication. If it is uncontrolled, definitely she needs a cardiac workup and management, echocardiography, TMT, and lipid profile, diabetes, hypertension before she can be prescribed. But it is not a absolute contraindication. Stroke not used to prevent stroke, and migraine, they can be offered. Transdermal route MHT can be given even to migraine patients. This is again an eye-opener. Thank you. How much time? It is over? Okay, 3 minutes. Yes, sir. I think we need a lot of investigations before we offer MHT. So this is premenopausal oral insufficiency. We need to rule out the secondary family history, idiopathic. We need to rule out secondary genetic causes like Turner's, FMR, infectious diseases, autoimmune. Other investigations, we've already ruled out adrenal cortex, 21-hydroxylase antibodies. This is the baseline evaluation for any starting of MHT is like VTE, metabolic disorders, osteoporotic fracture risk, and psychological health, their lifestyle, smoking, alcohol, diet, family history of any cancers, and of course pelvic USG, CVS assessment, BMD, breast screening, and a cervical cancer screening is the workup before we can start. Small note on estrogen. It can be given like only in post-hysterectomy combinations if they have a uterus, if they have comorbidities, transdermal, vaginal estrogens if they have like risk of breast cancers, and sexual dysfunction. Estradiol soft gel inserts 10 microgram have done wonderfully for people who have sexual problems. Progesterone as monotherapy, lot has been done for this, and you can see there is no effect of progesterone cream in sleep, psychological, physical, cognition, or sexual health, or fracture health, fracture or prevention of osteoporosis. It is vasomotor symptoms. Beneficial effect of DMPA has been there. So people who have contraindication for estrogen and they have a lot of vasomotor symptoms, you can still try progesterone. Testosterone, we don't use testosterone here. Well, I was in UK and there was a clinic doing testosterone, but again, estrogen is better, and tibolone has some goods, and that's my finish. Thank you. Thank you for your time.
Thank you, ma'am, for very...
Yes. Mm-hmm. Yes, only a short time for vasomotor symptoms, ma'am. Yes. It reverses also. Thank you, ma'am. Thank you.
Thank you, ma'am, for the comprehensive and brief explanation of do's and don'ts of MHT.